You know, when someone survives a heart attack, you'd think the worst is over, right? That the battle's been won. But what if that's just the start of a whole new and often silent challenge? Today, we're going to dig into that critical time after a heart attack and uncover a huge gap in care that leaves way too many people at risk.
Okay, let's just jump right in. Surviving your first heart attack is a huge deal, no question, but it also puts you into a brand new, very high-risk category for having another one. And the numbers on this, well, they're absolutely staggering.
So this number, it's not from a lab. It's from a real-world Canadian study. And it is shocking. Almost half. Let that sink in for a second. Nearly half of all patients who have a heart attack will go on to have another major event. I mean, this isn't some small risk. It's literally a coin flip.
So that brings us to the big question, the mystery we're really trying to solve here. We've had these powerful drugs like statins for decades now. So what's going on? Where's the disconnect that's causing this massive rate of recurrence? All right, so to start unraveling this, we have to talk about the undisputed champ of heart health for what? The last 30 years? Statins. These things were a total game changer, and they're still the foundation of how we treat and prevent heart problems. And look, there is zero doubt that they work. The science is crystal clear. For every 1-point drop in your LDL-C, that's your bad cholesterol, you cut your risk of another major event by a solid 20 to 22%. That is a huge benefit, and we see it over and over again in studies. Okay, but here's the catch. Statins are amazing, but they can only do so much. If you've already had a heart attack, your risk level is through the roof. And for a lot of those folks, even the strongest statin just can't get their bad cholesterol low enough to give them the best possible protection. Something's clearly missing from the equation. So let's dig into the evidence. Let's be detectives for a minute and follow the clues from some real-world data to figure out exactly why this care gap exists and why so many people are left so vulnerable.
First clue? It's right there in the numbers, in the blood work itself.
So a big study in Canada looked at these high-risk patients and found their average bad cholesterol was 2.08. Now, 2.08, maybe that doesn't sound crazy high, but the new guidelines, the modern thinking, says that target should be under 1.8. And that gap, which looks small on paper, it represents a massive amount of real-world risk for these people. Okay, so clue number 2 isn't in the blood, it's in our behavior. There's this phenomenon called clinical inertia. It's basically a delay in the system where doctors and patients just don't step up the treatment, even when the numbers are telling them they absolutely should. And wow, this next bit of data just lays it all out so clearly. So in this study, they asked doctors, hey, your patient's cholesterol is still too high. Why didn't you add a stronger therapy? And just look at the answers. About a third of the time, the patient actually said no. But almost just as often, the doctor just didn't think it was needed. And then there's cost, a huge barrier, especially for those newer, more powerful drugs. It's not one simple thing, it's this whole tangled mess of reasons. And all those reasons add up to some pretty scary delays in the real world. I mean, look at this. It takes on average 4 months just to add the next level of drug, ezetimibe. And to get to the really powerful stuff, the PCSK9 inhibitors, almost a whole year. That's a year that a super high-risk person is walking around with cholesterol levels that are way higher than they should be. So we've got this problem, this care gap. How do we fix it? Well, the answer is basically a brand new playbook. It's laid out in the latest guidelines from the Canadian Cardiovascular Society, and it's all about being way more proactive. This new approach is super clear and, frankly, aggressive. It's a simple 4-step plan. First, you hit it hard from the start with the max dose of a statin that the patient can handle. Second, you don't wait around. You check their levels fast in about 4 to 6 weeks. Third, and this is key, if their bad cholesterol is still above that 1.8 target, you don't hesitate. You add another therapy right away. And fourth, if you're still not at the goal, you bring in the big guns, the most powerful drugs available. The days of waiting a year, they're over. So we mentioned these big guns, the PCSK9 inhibitors. What are they exactly? Well, they're a newer type of medication. You take them as an injection, and they work completely differently from statins. What they do is they basically supercharge your liver's ability to grab bad cholesterol and pull it right out of your blood. The results are, well, they're pretty dramatic. Okay, now for what I think is the coolest part of this whole story. We've been talking about numbers on a lab report, right? But what's actually happening deep down inside the arteries? This is where we get that aha moment. This is the part that shows us why this whole aggressive strategy really works.
Okay, so check this out. In a study called HUYGENS, researchers took a group of people who just had a heart attack. They were all on a strong statin already. Then they split them in two. Half got a placebo, and the other half got a PCSK9 inhibitor added on top. And then, and this is the amazing part, they used this incredible imaging tech to literally look inside their arteries and see the plaques up close.
So, first things first, let's look at what happened to their cholesterol levels. The group that got both drugs, their average bad cholesterol dropped to just 0.7. Now remember that target we talked about, under 1.8? This is less than half of that. It's an insanely low level, way lower than a statin could ever get on its own.
But that's just a number, right? Here's the real million-dollar question. Does driving that number down so low actually change the plaques themselves? You know, the dangerous, unstable gunk that causes heart attacks in the first place? The answer is a resounding yes. And what they found is absolutely profound. Imagine a dangerous plaque is like a little volcano sitting inside your artery. It's got this mushy, fatty core, that's the lava, and it's covered by this thin, fragile cap. Well, this combination therapy made that protective cap thicker by over 42 micrometers. It's like pouring a layer of super strong concrete on top of the volcano, making it way less likely to blow.
And that's not all. At the exact same time, it actually shrank the dangerous pool of lava inside. They measured the size of that fatty core, and it got smaller, by a lot. So now what do you have? You have a smaller, less angry core of lava and a much thicker, stronger cap on top. The whole thing just becomes way more stable.
And this is the whole point. This is the big takeaway. It is not just about a number on a blood test. This aggressive approach physically changes the plaques. It turns them from these ticking time bombs into something much more stable, like a harmless scar. And that whole process, that's what we call plaque stabilization. So let's pull all this together. We've seen the shocking statistics, we've followed the clues to find the care gap, and now we've seen the incredible science that shows us the solution. So what does this all mean for you or for someone you love? What kind of conversations should you be having? All right, here are the most important things to remember. First off, you have to know your number. If you've had a heart attack, you need to know your LDL-C or bad cholesterol. The target is under 1.8. Don't be afraid to ask your doctor, what's my number? Second, if that number isn't at goal with just a statin, ask about adding another therapy. Ask, what's the next step? Third, make sure you get a follow-up blood test scheduled. Anytime your meds change, you should be getting checked again in about 4 to 8 weeks to see if it's working. And maybe the most important thing of all, a second heart attack is not a sure thing. It's not inevitable. With the right proactive care, you can slash that risk. And that really leaves us with a huge and kind of hopeful question. We now have the proof that this works. We have the science, we have the guidelines, we even have pictures from inside the arteries showing us why it works. The question isn't, can we do better anymore? The question is, how fast can we get this new knowledge out there to everyone who needs it? Think about it. Could we finally be on the verge of making a second heart attack a rare tragedy instead of a common, almost expected event?